So while I'm waiting for my slides, I don't know if you noticed, but there's video monitors out in the lobby, and they list the daily activities. And at 2:30 today, the daily activity is listed as belly dancing. And so I listened really carefully, and Dr. Selby did not include that as one of the objectives for this meeting. So I'm going to hold him to that. So in addition to not being a belly dancer, I'm as Hal mentioned, I do run a small health services research unit attached to a safety net hospital, but I'm also a practicing cardiologist and have been a practicing cardiologist at this particular hospital for about 23 years now. So my perspective really, as I talk today about the case for a data-driven, research-based care in the safety net, really comes from both of those perspectives. And so Denver Health is an integrated healthcare system that includes both a hospital as well as a network of primary care clinics scattered around the city of Denver, including quite a number that are based within the school system. It also includes the paramedic system, the emergency care system for the city as well. It is typical for the safety net in that its patients are largely minority, about half Latino in Denver, African American and minority white population, all of whom are poor, essentially. The reimbursement, the financial structure of the hospital is again typical for the safety net in that many of the patients are self-care and about 20% are Medicaid. So overall, more than half are not commercial insurance. And importantly, Denver Health has a very strong academic affiliation with the University of Colorado that goes back to 1947, something that Florence Sabin started way back when. And I think that that's an important theme that I'll develop later on. So Denver Health is typical for the safety net in the patients that it serves and its revenue stream. Importantly, the revenue stream results in a very, very thin operating margin across time. Denver Health, I think, is a little atypical in two regards. One is its financial stability. It has managed to have to end each year for the last, gosh, I want to say 22 years now without operating at a deficit, a little bit unusual in the safety net, but also has quality metrics that are a little bit unusual. So here's a couple of them. The top one is an inpatient indicator showing that we've had inpatient risk-adjusted mortality in the lowest 5%, so best survival for at least 5 years running now. And this finding is robust across subsets within the hospital and robust over time, as this shows. The bottom one is an outpatient one, shows that our hypertension blood pressure control is in the top quartile. And I include this one really as kind of a disappointment. I think when we compare this metric to other things within our system, it's good, but it's not as good as we would like it to be. Top quartile is kind of not good enough. And if I have time at the end, I'll talk a little bit about where maybe some of the failures are in blood pressure control as they relate to application of new data, research, and value-based sorts of propositions. And so what I really want to do, again, I really want to try to be general here about the safety net and argue with myself a little bit about should a safety net provider put resources into providing care of higher value and should we become a learning system? And so let me argue yes here. And that yes comes when the measure of success is easily monetized and when the time to return is short. So when you really don't have much operating margin to play with, you really have to be careful about what you invest in. And so we really want to invest first and foremost in things where we can really carefully and explicitly prove to ourselves that we really are not wasting money on this initiative. And we need to know that pretty quickly. We can't be 2 or 3 or 4 years into a project before we discover that we're losing a lot of money. So here's one example. So this is an initiative to improved performance with regard to venous thromboembolic prophylaxis. A big problem for all hospitals, really. And so what this shows is that using, our standard techniques are to use lean methodology, so you get people all in the same room, you make them sit there for about 5 days until they figure out the solution, and then they've got to implement it quickly and show benefit quickly. And this was an initiative in VTE prophylaxis that shows that after initiation of the project in 2008, that there was a clear decrease in the amount of money spent on VTE prophylaxis. And the other half of this is that the rate of DVT and PE during that same time frame went down. So in other words, saving money, improved outcomes by using the best available evidence, organizing and motivating people to work on this together, giving it a high priority. In a system like ours where there's not a lot of money left over, you can really do this kind of thing. So, so that's the yes. When's the no, or when's the maybe? So when the measure of success is intangible, and when results might not be realized well into the future, examples of where the proposition is less clear when you have very few resources with which to play with this here. Here we go. Sorry about that. So this is an example. This is the title for the talk, the High Value Healthcare Collaborative. So I don't really want to talk too much about the collaborative in general. There's people here, Jim Weinstein and Brent James, who can talk about this much more authoritatively than I can. But this is a voluntary network of, I think, 19 healthcare systems around the country now that have come together, partially self-funded, now also partially funded by a grant from the CMS, the CMMI Innovation Grant, to work on improving the value of healthcare. So in other words, to decrease cost while preserving or improving quality. And these systems have been working together for about 3-4 years now on multiple areas of mutual interest. As I said, it's in part self-funded. So why would Denver Health want to do something like this? Why would we invest money in being part of a large-scale network like this when the return on investment might not be so easily demonstrated? So one of the first projects that this system has worked on is to look at cost and efficiency and outcomes for joint replacement, for total hip, total knee. So it involves a great deal of pulling of data, pooling of data across the system, really a lot of effort on the part of our people to do that sort of thing. And as I said, we've been working on this for a few years. I cannot show you a slide like I showed you for VTE prophylaxis that shows that our performance, either financial or clinical, with regard to this hip and knee stuff has made a difference at our hospital. I can't show you those data yet. But nonetheless, when we go back to our CEO and our leadership and they ask, should we really be doing this? Should we be investing resources in this? Our answer is yes, and their response is okay. And so I think, it's important, I think, to reflect a little bit on why that is. And I think it makes perhaps a different case for this value-based learning healthcare system than perhaps has been made previously in the panel discussion. But there's a couple things that I would point to as being really important, and a couple things that we bring up when we discuss this internally. One is that safety net providers are isolated, right? That we don't have any friends. If you look around our communities, we don't really have competitors. Nobody wants our patients, and everybody else's patients don't want us. So we tend to work in isolation. That lack of competition and that lack of local collaboration are both things that we would predict would diminish uptake of innovation, right? I mean, if you look at sort of models of uptake of innovation, collaboration, cooperation, as well as competition are both things that are contextual factors that increase the uptake of innovation. So one of the values for safety net providers in doing something like this and investing something like this is it gives you the ability to look from side to side and say, gosh, you know, these are our outcomes for our diabetic patients. This is how much we're spending on our heart failure patients. This is how much, what our length of stay is following total knee replacement compared to Mayo Clinic, to Dartmouth, to Intermountain. Very, very useful, powerful, motivating factors, right? Being able to compare ourselves to create a context for our efforts is really important. And that is one of the main issues. The other thing is something that we don't, is a really deep underlying issue that I think is really, really important. You know, whether we realize it or not, every day when we go through the door of our place of work, we are asking ourselves, why am I doing this? Why should I get up out of bed, drive to work, do this every day? And whether we recognize it or not, that question is there. And for people in the safety net, the answer to that question is not, I'm going to make a lot of money, or I'm going to have a lot of prestige or power or anything like that. The real motivations are that we want to do the right thing. And that I think everybody in healthcare wants to do the right thing. And for us, perhaps that's a more salient issue, a bigger part of why we do what we do. And appealing to that, I think, is really important. And I think we really forget that one of the most important aspects of quality, value, diffusing research, new knowledge, doing things better, is that it appeals to that very uniquely moral and idealistic motivation for doing what we do. And so if you really want to get people to work together, to pull together, to do the best that they can every day, I think you have to appeal to these sorts of things. And it's a difficult case to make to those guys upstairs, but I think ultimately that's one of the real reasons for why we're doing what we're doing. And I hope we'll talk a little bit more about that as time goes on. So I don't know. I think I'm just about out of time. So what I didn't prepare a slide for this because I wasn't sure I'd have time to do this, but I just wanted to briefly give an anecdote, a failure, right? I think, you know, when we come to these meetings, everybody wants to talk about their successes, and we all leave thinking that everybody else is doing a way better job than we are. And I want to kind of dispel that myth a little bit. So this regard is hypertension. So we did we were involved in a study about 5 years ago we had partners at Kaiser and at the VA, where we looked at home-based blood pressure monitoring. So we gave patients blood pressure cuffs. We taught them how to transmit that blood pressure cuff over the phone into our computer system. We had a pharmacist once a week pull all those data out, call patients, tell them what to do with their medicines. In brief, what we showed is that the patients randomized to that intervention had systolic blood pressures on average 7 millimeters lower than everybody else. So really very effective, more effective than any single drug that we could give people. And so, you know, wanting to work on this issue of better hypertension control, you know, we're only in the top quartile, we want to be top decile, brought that forward to our administration and basically said, you know, we can't do it. You know, what you really need is you need most of a pharmacist's salary to do that, and we can't justify that. The reimbursement structure is not such that you can do this sort of thing. And so we have a problem. We have a research-based solution that is demonstrated within our system, and we can't deploy it. And And so we watch our partners at Kaiser and at the VA have the financial structures where they can justify doing that sort of thing, and we can't. And so, you know, I think one of the other lessons that we haven't really touched on today is that our reimbursement system is fighting against us in large part as we try to bring research findings forth into the clinical realm. And I think that something we need to bring into this discussion today. So now I think I'm out of time. I'll sit down.
Thank you very much.